All right, now we reach Wolff-Parkinson-White. Super high yield, it's going to be on your step 1 exam or step 2. WPW is the most common type of ventricular pre-excitation syndrome. Be ready for this. The term pre-excitation comes from the fact that there is an accessory pathway here. It's called the bundle of Kent. It directly connects the atrial and ventricular myocytes in a location completely different from the normal conduction through the AV node. So the accessory pathway conducts electrical impulses much faster than the AV node because the tissue does not have the slow inward calcium conduction that's characteristic for the AV nodal pacemaker cells. These are faster sodium channels through the accessory pathway tract. So how does this translate to a delta wave, a shortened PR interval, and a widened QRS complex? So the stimulation of the ventricular myocytes through the accessory pathway occurs sooner than normal. This creates the delta wave that slurs the QRS complex. It'll also shorten the PR interval, right? So the depolarization of ventricular myocytes not through the Purkinje system means that some myocytes are depolarizing each other via gap junctions. This is very, very slow. Ions literally have to move through gap junctions to depolarize the cells next to each other. This leads to a widened QRS complex. Another important thing here is to understand that the refractory period of the AV node is much longer than the bundle of Kent cells. So this is a time where we may encounter a situation in which one of the tracts has finished repolarizing. So for example, the AV node has just finished repolarizing while the bundle of Kent has already initiated another depolarization. This is another time we can create a macro circuit where we can swing around and depolarize through a macro circuit that goes through the ventricles. Now we'll create a huge loop of depolarization that will go from the ventricles back up into the atria. This is extremely dangerous because the depolarization can then come back down the opposite side of the connection and depolarize the ventricles again and loop over back on itself. This is dangerous because there's no AV nodal delay for diastolic filling. Now what about atrial fibrillation? On this slide we have a sketch of AFib and also what happens electrophysiologically. So think about AFib as multiple little microcircuits of depolarization in the atria. There is no synchronization of atrial myocytes, and there's no unified contraction, because if there's no synchrony, none of them are going to contract at the same time. So do you think that we will have a distinguishable P wave on the ECG? No. We only get a P wave when all the atrial myocytes depolarize simultaneously to create one mean electrical vector. This explains why P waves are absent in AFib. Look at this. There's no P waves that you can see anywhere. So in AFib, the electrodes detect chaotic and irregular individual depolarizations. So instead of equally paced out normal P waves, we get this. Irregular baseline with absent P waves. The irregular baseline with strange P wave, little squiggles, and random RR intervals represents the fibrillation within the atria. So why are the RR intervals irregularly spaced out? Well, the SA node is not setting the rate of depolarization. All of these tiny little wavelets of depolarization are randomly depolarizing the AV node. They're in charge. So this means that the ventricles are also randomly getting these depolarizations whenever they hit the AV node at the right time. So QRS complexes occurring at different intervals create different RR intervals. They are not equal to each other. So what do we need to do? Well, we need to try to slow down the AV node. We can rate control the AV node so that these rapid little atrial depolarizations do not continuously pass through the AV node into the ventricles. A great way to do this is with a medication such as a beta blocker or a non-dihydropyridine calcium channel blocker. We can also use digoxin, but that is not first line for this stuff. You could also directly try to control these little wavelets of depolarization. These random foci of depolarization in atria can be controlled with a class 1C or a class 3 antiarrhythmic. This is called rhythm control because we're directly targeting the little wavelets of depolarization that are responsible for the abnormal rhythm. If all else fails, you can just shock this patient to cardiovert them and get their myocytes back to normal. So why do we place these patients on warfarin? So a fibrillating atrium is dangerous because it eliminates the atrial kick. Remember the atrial kick that pushes the last bit of blood into the ventricle. In addition to that, when it's quivering, there's no unified contraction, so it's literally setting us up for a bad situation of blood stasis. This means blood has an increased chance of forming a thrombus or clot in the atria. We need to place these patients on warfarin or Coumadin, whatever you want to call it, to prevent a clot from forming, because if it does form a clot, this can easily break off and just send an embolus into the left ventricle, into the aorta, and up into the carotids, and up into the brain, and then we can infarct something like the middle cerebral artery, which is definitely the situation in this poor patient. This is an infarction of the middle cerebral artery. Now let's talk about atrial flutter. In atrial flutter, there's an abnormal, large anatomical electrical depolarization loop in the right atrium. The wave travels up the intra-atrial septa here, across the top of the atrial wall, down the right side of the atrium, and finally between the tricuspid valve leaflets here. There's only one loop and it's large. It's literally this big. It makes perfect sense when you look at the ECG. This is sinusoidal sawtooth pattern. Look at this. It's very regular. That's because this loop is going up and down, up and down. It's very regular over and over. Now, atrial flutter can be a problem depending at the rate at which the AV node is depolarized. If it's getting hit by these loops very, very quickly, that is a dangerous situation. So what we usually do is we just stick a catheter in here and zap this circuit and completely obliterate it. Most of the time, though, people will elect to manage it like atrial fibrillation. Now, VFib, this is super dangerous. If you look at the rhythm strip, can you see any identifiable waveforms that look normal? No way. It looks like someone was drunk and tried to draw a landscape on the ECG paper. It looks like a bunch of mountains, right? There's no discernible rhythm. It usually starts from a ventricular tachycardia, when the depolarizations are happening so fast that you get some ionic imbalances that you eventually lead to a disruption of synchronization. Essentially, we have created multiple reentrant circuits that are occurring at many different times, and that's why there's no discernible rhythm. No myocytes are depolarizing together or contracting together. Now, that's the problem. No coordinated single ventricular contraction means there's nothing ejecting blood into the aorta. That's why we do CPR, right? We mimic the ventricular contractions by pushing down on their chest. Now, how do we treat this? Well, we shock this person to hopefully obliterate all these circuits. We give them a big lightning bolt of electricity. We try to reset the electrical conductivity of the individual myocytes and hopefully terminate those little reentrant waves. Again, here we see these little wavelets of depolarization. This is just like AFib except in the ventricles. Now we come to the section that examines the different conduction abnormalities that occur in association with some sort of change in the AV node. The key to understanding these are understanding the PR interval. The PR interval is the onset from the P wave to the onset of the R wave. So AV block is a delay or interruption in the conductance, either temporary or permanent, due to molecular, anatomic, or functional problems. Let's talk about first degree first. So first degree is usually just due to a decrease in conductance through the AV node. This is just a temporary slow conduction. Now, second degree is a very, very sharp decrease in conductance. The second degree drop is worsening conduction that causes you to lose some impulse propagation from the atria into the ventricles. And third degree block is a complete block where there's no conductance from the atria through the AV node to the ventricles. There's no propagation of anything to the ventricles at all. So let's start with first degree. It is benign and asymptomatic. The prolongation of our PR interval is just telling us that for some reason our PR interval is above 200 milliseconds. You don't need to treat this, but notice how all the PR intervals are equal to each other. Second degree, Mobitz type 1, sometimes called Wenckebach, this is a little bit more intense. Now we have increased the degree from 1 to 2. If you've increased the degree from 1 to 2, then you must have an increase in the severity of nodal dysfunction. The ability of the AV node to conduct the impulse will get worse and worse until eventually we drop a beat. Notice how there is no QRS complex there. So the ability of the AV node to conduct the impulse will get really bad, and eventually we lose the ability to conduct at all. So there's no QRS. This is often described as having a gradually lengthening, increasing, so here it gets longer, 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 until boom, no QRS at all. So the P wave is all alone because eventually the AV node cannot conduct the atrial depolarization, and there's no depolarization of the ventricles. So now let's take it up one more notch and go to type 2 second degree block. The difference between Mobitz type 1 and type 2 is that there's no prolongation of the PR interval here. These are all equal to each other. Why? Well, it's kind of a misnomer, but the problem is that it's not truly within the AV node. It's actually in the His common bundle, directly under the AV node. The PR interval is normal because it's not affecting the AV node. The impulse goes from the AV node fine, and when it hits the His Purkinje system, that's when the problem happens. The depolarization fizzles out and does not make it into the right or the left bundle branches. This translates to PR intervals that are similar to each other, but then all of a sudden, boom, no QRS complex because there's no depolarization of the ventricular myocytes. So type 2 is usually due to fibrosis secondary to healing after a myocardial infarction within the bundle of His. This is a risky situation because you always need to have depolarizations reaching the ventricles. Now what do we do about this? Well, we pace them with a pacemaker. We stick something in there, so just in case a depolarization does not make it, the device will sense it and then it will shock them to simulate the depolarization making it to the ventricles. Now the last one is the most intense. This is complete third degree block. So we discussed how type 1 Mobitz was a dysfunction of the AV node, and type 2 Mobitz was an abnormality of the His system under the AV node. So naturally you would expect the third degree block to be worse than those two, and guess what? It is. Third degree block is characterized by complete dissociation between the atria and ventricles. There's no communication at all. The atria will depolarize in response to the normal SA node, while the ventricles are being told what to do by an ectopic pacemaker down here, an ectopic beat. So the atrial rate is faster than the ventricular rate because the intrinsic rate of depolarization of SA node is 60, right? While the ventricles are usually beating at a much slower rate. So this creates a complex dissociation between the atria and ventricles, so there's no discernible relationships between P waves and QRS complexes. Examples of this are in the tracing in your step 1 book. Notice how there's a P wave on a QRS complex. That's not normal, right? That means the atria and the ventricles are depolarizing at the exact same time. Or we can have a situation when the ventricles are repolarizing while the atria are depolarizing. This is a P wave on T wave situation, right? You can also have a P wave on an ST or T complex. An ST-T complex is just another way of talking about repolarization because it can sometimes be difficult to determine where the ST segment ends and the T wave starts on the ECG. Now, an extremely high yield association of third degree block is Lyme disease. So what is the spirochete responsible for Lyme disease and how does it lead to third degree block? The arrow is pointing to the spirochete that we're talking about. This is Borrelia burgdorferi. In advanced stages of Lyme disease, these bacteria disseminate hematogenously in the blood, right? So guess where they're going to end up? All over the body, right? Including in the heart. This is a biopsy of a cardiac specimen. So guess what's going to happen? The immune system is going to recognize these bad boys and then start sending antibodies in here and start sending inflammatory cells. Well, we're going to clear the bacteria, but we're also going to damage the myocardium. You can see here, this is muscle, right? So we trigger a local inflammatory response. Bacteria are going to be attacked at the expense of surrounding cardiac and conduction tissue. So this is how we get third degree or complete AV block with Lyme disease.